We then share them. So again, welcome everyone to Bananas. Thank you all for coming, and Ling, you're on. Go ahead. Let's see if you can share.
Okay, I will present my case. Wait a moment.
Thank you. Okay, we don't see the presentation yet.
Yes, I will find the show my presentation the seat. So I first to
Okay.
use the Apple. So sorry, I'm sorry.
Okay. I think it's
Yeah, sorry. Okay, I send a request to show my case.
great. Yeah.
Yeah, please.
Yeah, you should be able to.
So if you have the another one presentation, can you first to take
Okay.
a
Yeah, let's move forward
so
with someone else.
thank you.
Okay. All right. Let's see. Ying Ying, can you hear us?
Professor, I get the presentation, so I can first one. So I'm sorry. I find it.
Okay, try
So
now. Right, try now.
thank you. So can you see my the screen?
Uh,
Can you?
uh, yes, but we don't see presentation yet. It's a okay, now we do. Great. Yeah, we
Yeah.
see it.
Thank you. So can I begin for my
Please.
presentation?
Yeah,
Oh,
go
thank
ahead.
you. Yeah, good morning, professors, everyone. I'm Li Huang from the Department of Neurosurgery at the State Affiliated Hospital of Sun University, located in Guangzhou, China. It's a great honor to be here. The title I am to report on is flow diverter implantation for intracranial aneurysm with concomitant cerebral infarction. In the clinical physics case report, I will report the three parts. So the first case presentation This is a 51 years old male who was admitted to the hospital 10 days after being diagnosed with left ICA of Ischemic aneurysm due to ambiguous speech. The patient has a history of hypertension and hyperlipidemia for over 10 years and has been smoking for over 30 years. The GCS is 13 point, NIHS is 4 point. Uh, the examination result shows plaque formation in the both carotid arteries of the patient. Meanwhile, the hand MRI revealed subacute cerebral infarction in the left basal ganglia region. So through the CTA, MI, and DSA, you can see the unreptured small wide next intracranial aneurysm of in here. You can see it is a small unreptured aneurysm of the left ICA of usual segment. You can see the three the DSA. And so the diagnosis of the case is very clear. Cerebral infection is treated with double antiplatelet lipid lowering therapy, and the pressure control intracranial aneurysm is scheduled for surgery after 21 days of the onset and stable neurologically status. According to the operative DSM measurement data, we plan to use 4.25 meter by 16-meter pipeline to treatment this aneurysm. And we can see the video. After 3 weeks, the onset of the cerebral infection, the patient became stable status, so we can use the pipeline to treatment this aneurysm and this safe for our patient. And the surgery is smooth and successful. We carefully to use the pipeline and slow to to plan to implantation. And after our surgery, we can see the agent remains and the stent is attached the tough to the the arterial well. We can say is successful to open. And after surgery, we also to use the DABT therapy and lipid lowering therapy, blood pressure control. The patient is unremarkable on the third days after surgery and discharge. After surgery, we have to the for the 12 months mid-term follow-up shown that the patient's speech is fluent and the strength of the right lumbar was normal. The aneurysm has been completed cure, and both the cerebral infection region and the aneurysm has disappeared. We can see the video. We can see contrast to the before our surgery, the aneurysm was disappeared. Just became we know say the aneurysm the small aneurysm was disappeared after 12 months. And we also have a long time follow-up uh, the long time upflow of results of 36 months was same as above, and the aneurysm was no recurrent. We can see the another DSA video, we cannot see a small aneurysm recurrent, and we can see the MR, the uh, left basal region, ganglia region is also became normal. So we have a brief discussion. Epidemiologically, the coexistence of unruptured intracranial aneurysm and chronic phases cerebral infection is recognized but not uncommon. Studies have shown that 3% to 5% of patients with cerebral infection have unruptured intracranial aneurysm, while 1% to 2% of patients with intracranial aneurysm develop acute infection during cerebral embolization and or hyperperfusion. The existence of cerebral infection and the intracranial aneurysm present a particularly complex clinical situation. If a patient with cerebral infection experiences aneurysm rupture and bleeding, the condition became critical, complicating treatment and potentially leading to poor outcome. The period between 6 and 21 days after cerebral infection onset is generally defined as the subacute phases. Transition to the chronic phases begin after 21 days. During the chronic phases, and vascular treatment is generally avoided due to the risk of reperfusion injury. So in our case, a patient with intracranial aneurysm is absolutely cerebral infection beneficially from flow diverter implantation during the chronic phases. The approach not only treatment the aneurysm and prevent hemorrhage stroke, but also permitted the continuation of DAPT therapy for cerebral infection management. Although DAPT is routinely used to prevent cerebral embolic events in cerebral infection, it carries elevated risk of hemorrhagic transformation, particularly during the acute and subacute phases of stroke. In this case, the patient received DAPT to prevent cerebral embolic complication. However, follow-up imaging and clinical evaluation revealed no evidence of hemorrhagic transformation at the infection site. So finally, to summarize, the flow diverter established in the vascular device represent advanced therapy option for managing intracranial aneurysm. In this case, it facilitated the simultaneous control of the aneurysm and cerebral infarction, resulting favorable clinical outcome. However, further studies are required to confirm the generalizability of this finding. So finally, thanks for your attention. Thanks again, Elder Professor. I'm honored to participate in the banana course, and I warm welcome everyone to Guangzhou. And I'm very honored to have participated in the banana course in New York at the end of April. Thanks very much for Professor Mascam and Professor Elton. Thank you. I'm ending for my presentation. So can you take a discussion for me? Thank you, Professor.
Thank you. Thank you very much.
Thank
Um,
you. Thank you.
And thank you for staying on time. We have 10 minutes is good. Let's
Yeah.
let's have comments, please. Questions,
Okay.
comments.
Okay.
The yeah, yeah, thanks for doing this. So I think if anyone has any questions or comments, please speak up. Um, the big obvious question, as you alluded to, is what is the connection between the stroke and the aneurysm? I mean, that's within what you were within the some of the literature that you mentioned. Uh, the big question is whether something is caused by something or if there's an association, right? Causation versus association. And it's a very hard thing to prove, actually. If you think of like in general, it's very hard to prove when something is connected or causal, if something causes something else versus is being associated with something else, like a large aneurysm, for example, causing an embolus from a partially thrombosed aneurysm, or a smaller aneurysm being a bystander. The aneurysm is one thing, the stroke is another. And as you mentioned, 2-3% of people have aneurysms. Could they just be a coincidence? So that's really the discussion. I think the treatment is good. Once you decide to treat, I don't see the result is good. The technique seems good. Any comments? Any other questions?
I mean, this is also unlikely to be um, embolic, right? I mean, it's sorry for the echo. It's a lenticulostriate infarct. There's nothing else. So this really suggests another cause, right? As you said, 5% of people have aneurysm, more or less. So 5% of stroke people will have aneurysms. So I think it should not be the justification to treat the aneurysm. Let me put it this way.
Yes, I'm very agree with Professor Maskerman, Professor Gayton. Yeah, our the presentation is uh small small case for presentation, and we know this lower happen in our clinical treatment. So we just to uh pre the case to show for everyone to think when you get a stroke patient and he also have aneurysm, mm, like our case. So I mean we can wait a moment to treatment, not not to therapy in the immediately. It's all mine. So thank you.
If I may add something, of course, there is a connection when probably the aneurysm is large, partially thrombosed. That's more possible, but especially when the aneurysm is part of a dissection, so dissecting aneurysm, which might be also rounded like then it's a different thing. It's an aneurysm maybe on the perforator, so that's obvious that may have caused the ischemia, or even an aneurysm which is close to the ischemic territory. If the dissection is by itself a possible cause of ischemia and of aneurysm. So in those cases, I think the two things are more connected. In this case, as already said, I thought that it probably were two different things.
Can I say some words?
Yeah, of course, Ni. Go
Yeah.
ahead.
Yeah. So this is a very common situation in China that a patient with aneurysm and simultaneously with the atherosclerosis, like some patient presented with stroke. People will say that if the patient with history of stroke used antiplatelet therapy, it may cause the higher possibility of the aneurysm to be ruptured. But based on the literature, which I don't remember very clearly, maybe 10 years ago, and some hospital in China they perform such kinds of clinical research, focusing on the the relationship between the antiplatelet therapy with the rupture rate of the aneurysm, but they found there is no link between these two factors. So people will question what is the indication for this aneurysm? Why you should treat them? Are
Right.
you afraid of using the antiplatelet therapy will cause its rupture? I don't think so.
Right. Yeah,
Or
that's
or really, but based on the previous literatures, they only focused on the mono antiplatelet therapy like the aspirin or use the clopidogrel alone. But if we use the dual antiplatelet therapy, is there any possibility that it will increase the rupture rate? I don't know. But for me, this is not a good case for for the treatment. This is my comment.
Okay, thank you, Professor Ni. I mean, in the situation we to meeting the family of the patients, he want to treatment, and we also know the guideline for treatment enzyme is too small, but we try our best to wait after the stroke to chronic phases and to treatment the enzyme. We also to talk with his family to just to follow up with MRI or CTA, but he families want our to help he to treatment the enzyme is our case, but not every case should be treatment. Thank you.
Yeah, I mean, I'll definitely agree that the longer we wait between the infarct and the treatment, I think the safer the treatment becomes. So I think that's an important factor. I want to show something just a little bit. Just give me 1 second to set this up. I can't help let me see if I can do this.
So I can stop my show, Professor. Can I?
Yeah, if you could, let me share this case here because I think it's kind of interesting as we speak to etiology of aneurysms. This is a case we did recently. It's a patient who presented with a lenticular striate infarct, kind of similar to what you had in your case. And you see, now most of these, and as we know, in terms of etiology, it's relatively unlikely to have an embolus into this. And so we suspect that these are caused by stenosis typically. But we are not able to see it because of the resolution of our imaging, but now we can. So this is just kind of in terms of diagnosis as we explore association between the aneurysm and the infarct and what is the cause. Here's an example of someone who has actually bilateral infarcts. There's one on the right as well, more chronic one. Obviously, there's not much to see in the 2D image, there is some atherosclerosis in the M2 segments or distal M1s, depending on how you think about it. But we wouldn't expect that to result in a lenticular straight infarct. Now, when we do 3D type imaging, right, there's, again, if you do this general image, you're not going to see very much. We have to do secondary reconstructions, more advanced imaging. And indeed, when you do this, look, you perfectly can see that there's a critical stenosis right here of this proximal lenticular striate vessel. It's a very dominant lenticular striate trunk. As you can see, it's a large one. And there's the stenosis. So that corresponds. So now we have more imaging etiology of something like this, which I think is what usually this is. Does it change management? No. But I think this is a step towards better diagnosis. So I just wanted to share that because more and more we are able to see this. And I can see it I can show you the one on the other side, but if I do, it's going to show up the patient's name, and I can't do that. So let's leave it right there.
Thank you.
Okay.
Thank you for your guidance.
Yes.
I'm very much thank you for you. Thank you.
Thank you. Okay, there was a question from Iron Man, concern about the risk of rupture due to use of antiplatelets. Okay, that's another question. Like, is the aneurysm more likely to rupture once the patient is on dual antiplatelets? It's definitely going to bleed more if it were to rupture. I think there's more agreement on that. There's not really good agreement as to whether aneurysms can rupture once patients are in dual antiplatelets. Anecdotally, we have had aneurysms. I'm sure others here have had examples of starting somebody with a large aneurysm and dual antiplatelets and then having the aneurysm rupture. And then the question becomes, did that precipitate the rupture or was it just time to go? I think here there's some room for debate. Okay.
Yes.
Ying, can you hear us?
Yes, I hear. So yes, the situation is common, and we know the double amputated is not acute the rupture of the aneurysm, but when we get this complex case, we need to think save our patient. So I think this the stroke and with the aneurysm is not the directly situation correct association, but we just show a case when we get the patient, but not we don't to talk everyone. This case should be here. We just successful to cure this case, but we have not another experience to treatment those case. We need a regular study to find the result. Thank you.
Yeah. Thank you. Thank you.
Thank you.
Thank you very much.
So
Okay.
I can I stop the show?
Yeah, you can
Professor?
close the presentation.
Okay,
And
thank you.
you're on.
Thank you.
So I will show it's my turn?
Yes, please. Thank you.
Thank you. Can you see my screen?
Yes. We don't see the presentation mode. Okay, yeah, perfect.
Okay. Oh, let me check. Okay. So, hello everyone. I'm Dr. Zhang Ying from Shanghai, and today my presentation is about endovascular treatment for ACOM aneurysm. So this is a 73-year-old male patient who complained of dizziness for 3 days. And the patient, the physical examination revealed neck resistance, and the CT scan revealed a small amount of ACH. Okay, so the rotation angiogram revealed the ACOM aneurysm, which has an extremely irregular shape, and also with the absence of the contralateral A1 segment. So to illustrate the aneurysm, I draw a picture which reveals the geometry of the lesion. So the patient located on the ACOM segment and involves the left A2 more. And to protect the left A2 segment, maybe we needed a wide stent. And also we needed the microcatheter over the dome technique. But I think it's quite dangerous for this kind of irregular shape aneurysm. So I think the stent-assisted coiling, the single stent-assisted coiling is quite rational. So I performed the Atlas 3/21 from the right A2 to the left A1, and the coil as many as possible to make every bulb of the aneurysm was filled by the coils, and the patency of the right A2 and till the slow flow in the left A2 segment. So I think it's the time to stop the coiling. Also, we use the intravenous infusion during the procedure. Okay, the 1 day post the procedure revealed no infarction for this patient, and the patient was symptom free. And so we prescribed the patient with regular dual antiplatelet therapy. However, at the 1 year follow-up, the angiogram revealed the recurrence of the aneurysm, and still the geometry, the picture of the aneurysm revealed the recurrence region of the aneurysm, which is around the origin of the left A2 segment. So for the second session of the endovascular treatment, we have several strategies. First, the coils alone, or overlap stent or wide stent plus coiling, or clipping is an extremely different kind of strategy for this patient. And also we can use observation and waiting, but considering the aneurysm was a previously ruptured one. So I think to treat the recurred aneurysm is rational. So I used the flow diverter to treat the patient, which was deployed, which was planned to deploy from the right A2 to the left A1. So you know that we all know that to across the Atlas stent is not easy sometimes. So first to use the 70 microcatheter to across the Atlas stent. Okay. And to make sure that the microcystin was within the stent, I use multi-angle fluoroscopy to confirm that the microcatheter along with the wire was within the center of the stent. Okay, then to double check with the system within the stent, we use the exchange technique to use the 27 catheter. We know that the micro wire has a gap. There is a gap between the micro wire and the 27 catheter, but you can see that the 27 catheter goes through the stent easily. So we think it's right within the stent. Then we deployed the domestic flow divert, whose name is the lattice, with the 2.9/20. The flow diverter has several characteristics. It has a mechanical bloom within the stent. We can, which is more helpful using the in-situ deployment. And we know that it's not easy to deploy the flow diverter within a tortuous vessel, especially with the lumen size change for the lesion. So reopen and the restrict of the flow diverter cannot make it open and up position quite well. So it is decided to deploy the flow diverter and using the post processing technique to make sure the good apposition of the flow diverter. We can see the length is quite good, which cover the whole length of the Atlas stent. Okay, so open from the tip to the tail. And we also see that the flow diverter has not a good position at the proximal part. So I used a 2.5 millimeter balloon to plan to dilate the proximal part. However, during the tension adjustment of the system, the proximal part of the flow diverter has quite good position. And we used the semi-compliant balloon here, which is the balloon for the stenosis therapy, and quite a stiff system. Then we think the proximal part has a good position. Then we observe the flow, but we can see that the anterior cerebral artery flow getting slower, and then the flow stopped at the ACOM level. So we needed to super select the 17 catheter again through the flow diverter. So it's not a proximal part problem, and I think it's quite right the region which was not easy, which was not well positioned during the deployment of the flow diverter. So we use a small size balloon, which is 1.5 millimeter. For the segmented multi-dilation and the different angle fluoroscopy to make sure that the flow diverter has good position at the lumen change segment. So the balloon used here are the semi-compliant balloon instead of the hyper-compliant balloon. And we think if the vessel had a pre-existing laser cut stent, it's quite like the case for the patient who has the combination of the ICAS and aneurysm. So I think the semi-compliant balloon is better for this kind of lesion. And then final check still to find if there is any poor apposition of the device. And finally, the flow restored. And also the left A2 still a little bit slower, but the standing is within the normal range. So I stopped the procedure. The CT 1 day later also revealed no infarction and the patient is still symptom-free. Then we switched the dual antibiotic therapy to ticagrelor. And the 90-day MRS was 0. The patient is still under follow-up. Thank you for your attention.
Thank you, Ying. Thank you. Very, very nice case. Questions or comments? Okay, I have a couple of questions. Initially, I'm not sure if I understood. You said it was a switch in dual antiplatelet therapy. What was the therapy during at the time when you were implanting the flow diverter, the lattice? What was the patient on?
The aspirin and the clopidogrel before.
It was on clopidogrel after the Atlas stent, right?
Oh, yeah.
Did you keep on clopidogrel for the lattice, or did you go up to Berlinta?
Only after the flow diverter deployment.
Mm-hmm.
السر رزاش قاضي فما له وجه.
Okay. One kind of more obvious question would be to what extent the flow changes you saw after lattice are due to thrombus formation versus the configuration of the lattice within the atlas, especially since you see the differential kind of change in right versus left A2. The left A2 being quote unquote jailed may be more susceptible to sort of early thrombus formation and flow change if that were the case. And I'm not disagreeing with the balloon. I think the balloon is the right move. But with Plavix, we're always a bit suspicious.
So I think if the patient should be treated endovascularly, maybe this strategy, I don't think the Y stent is safe enough. Actually, I think if you use the Y stent, I think will increase the thrombosis during the procedure or even after the procedure because we have a difficult angle for the left A2 segment. And
Yeah,
also
no,
you
I agree. I agree. My comment was more like, it's not for Y stenting. My comment was more to say that if someone's on Plavix and if they're a hyporesponder, when we place a flow diverter as you did, it's possible that the flow change may be due to thrombus formation. In addition to, or maybe like to what extent does the configuration of the lattice play a role in that versus the thrombus? It's hard to know. It's very hard to know. There's another stent in there. So, that would be one question to consider.
yeah. Yeah.
Any other comments?
You're right.
I just wanted to strongly advise to not place a flow diverter inside another stent, especially if it's a laser cut open cell stent, and especially if this is on a curve, because the original stent will never be opposed to the walls of the artery. The laser cut stent will never be. It will always be in the middle of the artery, especially in the curve. So you will never be able to pass through. You think you are in the middle of the original stent, but you're not. You're just going in and out of the cells. So I learned that 20 years ago the hard way, meaning that I had unsuccessful flow diversion. So it's practically impossible. It's possible maybe with braided stent, or at least it's more easy, but certainly not. Beautiful case. Thank you for showing it, and successful case. But I don't do that. I'm not talking to you, but I'm talking to the group that are looking and now and are watching what we're saying. Try not to do that, because if you place a flow diverter inside another stent, usually it doesn't work, and you have complications. But beautiful case, thank you.
I think technically this was handled really well, right? As you said, Dodi. Like really nice passing the atlas. All of this stuff is handled really well. Like so, and it's not easy, right? It's not easy to do this, to put in a balloon. So we're really like, that's really impressive, honestly. I want to second Dodi's point, and I particularly am against using Atlas in these cases, or laser cut stents in general, because of exactly what you show. Like if it works, fine. But if the aneurysm is aggressive and behaves badly, and then you have to do something else, there are so many problems in trying to kind of fix the situation. So our kind of philosophy is there's so many reasons the factors to consider. But one important factor is what can we use that will allow us maximum flexibility in the future should things not go right? Like, can we not close doors? And in that regard, yes, there's no A1 on the other side. So I would be also kind of not into using flow diverter at first. But if we use a braided device instead of laser cut, I think it becomes much better later if the aneurysm, let's say you want to, say for some reason you want to cross into the ipsilateral A2, like do a flow diverter from like left A2 to left A1. That may also be possible with some braided devices. I think with the Atlas, it's a problem.
Well, Max, this is an emergency case. So if you use the braided stent, how to control the how to use the antiplatelet therapy? Because based on our previous, why we use Atlas so frequently in China? Because especially for the emergency case, because Atlas will cause much lower uh, thrombotic complications than the braided stent. If you use the braided stent, even for example, Elvis Evo like that, there will be higher possibility of the complications. So we prefer to use the Atlas.
Okay, that's an interesting point. And I think
Yeah.
that's a difference in practice patterns. Like, I don't think other places may not consider the difference as much in terms of antiplatelets for Atlas versus braided devices. So there would still be dual antiplatelets. But my answer to you in this is fine. If that's the case, then don't use the stent at all, right? Like in an aneurysm like this, I would strongly contend that it's possible to temporize this aneurysm with balloon-assisted coiling, that you don't need to place a stent. And certainly there are other reasons besides like Atlas or whatever not to place a patient with on any sort of dual antiplatelets within a subarachnoid hemorrhage. I mean, just looking at the 3D, the rotational that you showed, my guess is either balloon-assisted coiling, or if you are into like web or like one of these intrasaccular devices, I saw there was a second lobe, so there were several areas of coiling. So maybe, but that would be my strategy. Like my acute strategy is something like this. What do you think?
Yes, balloon assistant coiling will be the first choice, but this is a very broad neck aneurysm. So maybe web is another option. I don't know whether this is a good case for web. And I have a question for Ying Ying. And when you use the flow diverter, you put it in the contralateral A2, and then the tail of the stent will be in ipsilateral A1, right? And the patient have a hypoplastic contralateral A1. So how to control your antiplate regimen in the future? Because are you worried about maybe the further occlusion, chronic occlusion of the contralateral A2? This is my concern.
Yeah, we don't know. My answer is I don't know. Maybe we need takes time to answer your question. But I think if the left A2 segment remain exist, maybe the aneurysm recurrence cannot be stopped, I think. So so I don't know how can you do the balloon assisted coiling for this kind of aneurysm sac evolves over the maybe over the half of the lumen, the length of the ACOM segment. And the aneurysm had several bulbs, superior, inferior, anterior. So at different direction, the aneurysm has irregular shape. I don't know whether you can know that the coiling is sufficient to prevent the re-rupture of the aneurysm of this kind of lesion.
Yeah. Yeah, no, I think you know the pictures best. You've seen the aneurysm better than us. My point is only to say that to try to the extent that balloon-assisted coiling is also like something that people use more or less. But I think it's important I would try it at first to see if I could spare the stent. Because again, I think going down the road, the options may be better.
Okay.
I wanted to go back to the reduce the thrombogenicity of braided versus laser cut. You know, here when we say braided, we're talking about something like an Elvis, you know, a Leo baby. It would be in Europe that we don't have here. Is that something that you're absolutely sure and it's proven? Is there good literature about that? I mean, the amount of metal of okay, the Elvis Evo has more metal, but the old Elvis or the Leo Baby, they don't have that amount of metal, right? Maybe a little more than a braid than a laser cut. But is it something you're sure about, the higher thrombogenicity?
This is just my based on my impression. I don't have any literatures because I checked. Maybe there is some literatures describing the safety of the laser cut stent, but when I checked the literature, there is no such evidence that we use if we whether we can use the braided stent in the in emergency case. So I don't know the data, but based on my personal
Okay.
experience, yes, the braided stent will cause higher complication rate.
Higher.
Yeah.
Okay. Anybody else have something to say about this? All right.
I think in terms of something you said way about like what happens long term. I think long term results with this antiplatelet regimen, I think are actually quite good in terms of ischemic complications. I think at this point, Ying, like the probability of ischemic complication is low, especially if you maintain them on dual antiplatelets. I would suggest not to stop at like 3 months. Usually we extend to at least 6 months in this type of situation if there's no problem, if there's no bleeding or other issues. But I think the reorganization of flow, this person did have pretty decent leptomeningeal anastomosis. Like even in your acute phase, you saw how, more or less, I don't think it would have been sufficient. If the A2 closed during the procedure, there probably would have been an infarct. But based on how much the brain was already trying, I suspect that it will be okay. And hopefully what will happen is that the left A2 will close and then the aneurysm will go away with it. If, notwithstanding the non-opposition that Dodi is referring to, I mean, at least there'll be different flow modifications. So I'm kind of hopeful that this case will have a good outcome, is what I'm saying.
So I have a question for all of you. So if you use the flow diverter for the very distal aneurysm above the circle of Willis, and how long will you prescribe the dual antiplatelet therapy? More than 6 months?
You ask 5 people, you'll get 10 answers. This is what's going to happen. We do
Especially at a very
6 months.
tiny vessel, diameter below 2 millimeter, I think.
Yeah. I mean, we typically do 6 months. I've also seen cases where you come back in 6 months and the whole thing is closed asymptomatically. And again, like there's some sort of collateral refilling and everything is fine. My suspicion is a decent amount of these very distal aneurysms probably would be amenable to sacrifice, which we do less and less now because we have flow diverter options. But sometimes kind of nature proves that this might have been okay. So our answer is 6 months. I don't know if anybody, let's see what anybody else, what are other opinions?
Professors, I'm Zong from Nanjing, so I still want to go back to the point that we just talked several times about the stent that we should, which kind we should choose in the emergency. I mean, the ruptured aneurysm. I said this is a wide neck and complete complex shape aneurysm, which means it it was accompanied with the high rate of recurrence. So even during the emergency, just as Dr. Lee said, maybe the laser cut stent with less metal uh, uh, with little with less metal means maybe with lower risk of thrombosis, but for the braided stent, maybe it's with a more uh, higher risk of thrombosis. So, so my question is, how should we choose for the wide neck and the complex shape? In order to, for the long run, maybe we should choose the branded closed cell stent to decrease the rate of recurrence. But for the sake of the whole operation, maybe as Dr. Lee said, the laser cut stent is with lower rate of thrombosis. It's safer for us, for doctors, but it's safer for the patient if we use the branded stent. So how to choose? Thank you.
Yes. Rene, I think Rene raised a hand. Rene, can you unmute yourself, please? I know Rene is traveling, so they might have some connection issues. Rene, if you can
Yes.
maybe
Okay.
wanted to.
Yeah, sorry for
Yeah.
yes. Concerning the debate, I mean, definitely there is some increased thrombogenicity with braided stents. I would say braided stents are just like flow diverters light. So yes, they're more thrombogenic, but yes, they're more efficient. And the number of wires required for a braided stent to be flow diverting or not is something that nobody knows. So you can consider that if you add a lot of wires, I mean, do we need a 12, 16, 18, 23.2? Nobody knows. And that's why those braided stents are indeed very efficient and less dangerous. At some point, the more there's metal, the more it's at risk. And I strongly advocate for the use of those flow diverters lights in any aneurysm which is below 10, which is our practice. Concerning the use of stents age, I mean, it does not make sense. Why not do it? And it's okay, but it's of course at more risk because you need antiplatelets. So there's, in my opinion, no doubt that this should be avoided, and there are hardly aneurysms where balloon-assisted does not enable to do so. So, I mean, I strongly agree with all points that have been brought in by Maxime and Aitan.
Thanks, Rene. So I don't know if that, I think, if it answers your question. As Rene said, you're balancing what is the perceived advantage of using less metal and less thrombogenicity of the laser cut stent as you believe, or as some people believe, but not all of us believe, versus the efficacy down the road. And we know, I mean, I'm convinced that laser cut stents do nothing to prevent recurrence like beyond, it's just there to keep the coils in where we think we want them. But the recurrence becomes the major issue. And then it becomes so much more difficult to deal with it. That's the problem with them. I think is what we deal with this, and now we see this, from time to time, and it's just it's very difficult. Sometimes impossible to cross these. So I think on the whole it was handled well, and hopefully I think likely will be a good outcome for this person, right? An elderly person with an aggressive aneurysm. Um, but the discussion I think was very, very useful. Okay, let's move on. Ying, thank you so much. Very nice case and good discussion, I think. Let's see. Rami, can you hear us?
I can hear you. Yes, can you hear me?
Thank you. Yes, you're on.
Thank you. Thank you so much. So let me see how I can share. I wonder, are you able to see?
We can see it. We don't see the, yeah, that's good now. I think it's
Right
going to be
now,
good. It's coming up. Yes, we can see.
all right, sweet. Thank you. Good morning, everyone, and thank you for the opportunity to present the case today. My name is Rami Fakih, and I'm a neurointerventionalist practicing in Virginia, USA. The case today is about brain AVM, and we're going to discuss a hemorrhagic complication post-procedure. Hopefully, we can draw some good learning points from this case. So we have a 40-year-old gentleman who presented to the ED after he had a fall from 20 feet. He is only Spanish speaking, so I don't think anyone was able to gather really some good history. Why did he fall? What happened? So really, we cannot fully rule out that he had a seizure somehow. His exam was otherwise normal. And of course, he had a CT of the head, and this is the finding. This was read by the radiologist as a intraparenchymal hemorrhage, basically. So neurosurgery were called, they evaluated the patient, MRI was ordered. And as you can see, there is certainly a suspicion of AVM. We can see a large vein and surrounded by these abnormal looking vessels. So at that point, they consulted us for an angiogram. And this is the left ICA run. And indeed, you can see the AVM. And this is the lateral view. All right. So moving forward, we did a 3D, of course, and you can see it better. It does seem that there is two main feeders into this left frontal AVM. One is from the left ACA, callosomarginal branch, and one is coming from the MCA, one of the branches of the MCA. So the assessment is that we have basically a left frontal AVM. Now, was it a ruptured AVM? Was that a bleed really or not? Or was it symptomatic or not? All these are good questions that they could possibly be the case, but perhaps not 100% with the lack of really a good history. And as we mentioned, there seems to be mainly two main feeders, the left callosomarginal and the left MCA branch. We have superficial venous drainage. So we have that ectatic cortical vein that we saw, which after that drains into the superior sagittal sinus. It's about 1.5 centimeter in size, so it's a Spätzler-Martin grade 1. Now at our hospital, we don't have open neurosurgery and we don't have radiotherapy for AVM treatment. So we opted for endovascular embolization, given the location, the size, having two main feeders into the AVM. We thought this could be treated endovascularly.
Before you move forward,
Yeah.
can we discuss some of these points now, since I'm sure you're going to show treatment after? In terms of ruptured or not, yeah, it's true that the history is not there, but I think with imaging, we should try to really be a little more definitive. When you go to the initial CT, and this can certainly be a hemorrhage, but in this setting can also be a vein. And as we see, like it has the same density as the superior sagittal sinus on this image. The next image, which was the MRI, this shows definitively there is some bleeding. Right now, is that acute or chronic is unclear, but this susceptibility also extending to the sulcus on the right image. It's I think based on this susceptibility, I would say there was some bleeding. I don't know how acute or not, but I think even without the history, I would say the images support that. Max or other, do you agree?
Yeah, I agree. I would, for purist's sake, I would show an unsubtracted, pre-contrast T1, because I think if we're trying to date a bleeding, we need the T2 and T1 imaging. So in terms of that, yes. I mean, you have other points to discuss, I'm sure, in time.
Yeah.
Fabian,
the other point.
To me, I don't see yet any convincing evidence of a bleed here. So what you see is the hyperdensity of the vein on the CT, and I don't know if you're referring to the SWI. That's the one on the far left, and we have some hyper signaling there, but that could maybe a slow flow. Is there any hemosiderin seen in the cells? I don't see that either. So I don't think this imaging so far shows us a rupture.
I really like this. This shows how confidential this case is.
Now, can you go back to your slide with the points?
Yes.
There was another thing that you put this marking, Spetzer marking grade 1. I think here, like, we're really like very, very close to in the left side. It's probably is a grade 1, but that is obviously when we talk about eloquence, right? There is always like a little of gray zone, and I think here we're extremely close to eloquent areas. Let me put it this way, but I get it. It would probably go by grade 1. Do we agree on grade 1 here?
I agree.
Okay.
But I think, you can see, Rami, how you're getting, people are holding back comments, but you're getting into very dangerous territory. Like,
yes.
The obvious question is, if your hospital doesn't offer endovascular surgery or radiotherapy, the blunt question is, what does it offer for AVMs? How many AVMs are done? Does the ICU have the support? Do they have the experience to deal with AVMs? Should this be dealt in a hospital that offers all the options if things were to, go wrong? So we don't, we're just sort of, I just want to throw it out there because it's very like, this is the world we live in. Many hospitals don't have the full range of experience. Let's say they have one experienced operator, but not 3. So, that's obviously, that's it. Like, that's the setup. Tibor.
Yeah, thanks. So that's exactly, I wrote a comment while this was being said. So exactly my point. So two things that bother me. One is if the patient is Spanish only and you can't get good history, then how can you get a good consent? That's just one philosophical but practical question. The other thing is, I don't know what is wrong or right, but in my practice, in the last 10 years or 8 years, I've been working in a hospital where we don't offer surgery or gamma knife. I wouldn't touch a brain AVM because what you're gonna do if if something doesn't work out. Like, I feel like if I was on the table, I would want to be assured that the bailout options are available. So I personally don't feel comfortable dealing with brain AVMs. Those are my 2 points.
Yeah, very good points. Thank you. Let me clarify 2 things. Regarding the Spanish-speaking thing, no, we do have a translator, like on the machine. So that's how we're able to get some history and get the consent. What I meant is that it wasn't really clear, despite the history we're able to get, if the patient had a seizure, for example, we had like
yeah, that makes sense.
That wasn't very clear. And then regarding the second point, yes, like we do have open surgery, like we do have a neurosurgery service, but they don't do resection, like AVM resection per se. So yeah, it wasn't the ideal situation for sure, but this is what the service that we have here.
But I think this is an important point, and here is the thing: if essentially you don't have, surgery is not available as an option, and doing AVM treatment, endovascular treatment, that's something that is absolutely necessary to have, in the sense that even if they don't do plans, exactly because they don't do planned surgery, to have to do an unplanned surgery because something happens during the embolization, that's even a 10 level more difficult and more challenging. So by definition, if they don't do elective treatment of these, I would not rely on emergent treatment of AVM.
Okay. All right. Let's see what happens.
All right, moving forward. So the plan was as follows. We wanted to do a 2-stage embolization, perhaps embolize the smaller MCA feeder first, and then later on, weeks after that, bring the patient back and embolize the other feeder, the callosal marginal one. And at every point, we want to make sure during embolization that we're staying away from the vein. So we went the radial axis. We used a 7 French zebra catheter. Intermediate was a DAC 038. We used an Aristotle 14 as a wire and headway duo microcatheter, and we use Onyx 18 for embolization. So this was a picture of an angiogram from the DAC inside the MCA branch, and you can clearly see the branch that we are planning to embolize going into the AVM, and then we can see the cortical vein and the venous drainage. So we went in with a headway duo. We went as close as we were able to. Right here at the AVM, we did the micro angiogram, and we could see the AVM better. And we decided to embolize right there at that point. And this is the Onyx cast that you can see post-embolization. And this is a run from the intermediate catheter. This is another run. And it seems like at least partially the AVM is embolized, but you can still see the fistulization, the early venous drainage still occurring. So there seems to be another feeder for a different branch, perhaps. So we did another run more proximally, and indeed at that point, we could see that there's still a part of the AVM that's not embolized, perhaps from a different branch. And indeed, after some pictures, we were able to find the other feeder right here, which is just a different branch. So we opted to select that one as well. And we did a micro run. And at that point, you can see that there's this remnant part of the AVM that's still there. So we opted to embolize that branch. And this was the target vessel. Again, it's quite distal and superficial, so we were able to get as close as we could, and the tip of the catheter is right here. And we decided to embolize from there.
This
And
is
this
another
one-
headway duo, right? This is not
That's
a
correct.
flow-guided catheter.
Yes, that's another headway duo. Yes.
Okay. Okay.
And so we embolized there. This was the cast from that embolization. At that point, there was some reflux happening, so we decided to stop there. And post-embolization angiogram shows perhaps better embolization of the MVM. We don't see that other part anymore. And we did the more proximal run from the MCA itself, and this is basically the final result. So moving forward, and this was the ICA angiogram. So we can see that there doesn't seem to be any more feeding coming from the MCA, and now mostly it's from the callosal marginal. So at that point, we decided to conclude the procedure. We did a post-procedure DynaCT on the table. And what it showed, at least to my eyes, seems to be contrast extravasation, perhaps cannot fully rule out any kind of bleeding. I don't know if there's any comments so far.
Well,
I mean,
if contrast is there, then blood is there too, of course.
Yeah.
You know.
I mean, certainly, I think
but,
I think we have comments. So I have a comment so far on the technical aspect of especially the second catheterization. You're far from the AVM. There's absolutely normal brain there that you're gonna embolize, and I think as Max pointed out, when you start like going around like so distal, like really, headway duo is a great. I assume the 167 is a great microcatheter, but it's not the best, right? We know the Magic would perform much better in this situation, and you have higher chance to get closer. That second embolization is not an idle embolization, right? It's just a proximal embolization. So it's just it's actually it's not improving the occlusion of the AVM. It's actually making it worse. Those were my comment about the second catheterization. What you see on the images is a subarachnoid hemorrhage. You know, when, like, how was the pool? Was it at all traumatic, the pool, in either catheterization? You know, maybe the microcatheter was stuck a little with onyx. You pull, like, I think that's probably what it is from, but you know, it's
that's
anyway.
That's the reason why we started using detachable tip catheters, because every time you don't use that, you will have a rupture of something. You will have a hemorrhage by retrieving the catheter. I have many more comments, but let's go.
Yeah, the pull on the first one was fine. On the second one, yes, we had to do it. We took our time, and because there was reflux, so we stopped and we really took our time doing that. But the pull was not easy on the second one.
I'll say this, you know, before we go, just like at the beginning, you're saying that there's no, you know, surgery, there's no this, no that. Also, I'll be critical and I'll say that if we're doing embolization, we should also have everything. You know, the magique, the use of glue, which I think in this setting, you know, is something to consider, especially in a second. If we're gonna not, you know, we didn't even get to Rene and the transvenous option, but if we're gonna go with classical transarterial stuff, then distal catheterization and BCA, all of these things should be on the table. And that relates to better, you know, the pool is much easier if we're using glue, indeed. And I also suspect it's the pool that caused this problem. Doesn't look to be a lot of hemorrhage, so hopefully, you know, we'll see how this evolves. Okay, go ahead, please.
So moving forward, post-extubation, patient had a normal exam. He was transferred to the ICU. The goal was to keep the systolic blood pressure less than 130. And then 3 hours later, the nurse reported a new onset aphasia. And this was the CT scan that was done at that point. So now we can see that there is an intraparenchymal hemorrhage and that left frontal, which was not present there before. After 6 hours, the hemorrhage seems to be stable, and then we can start seeing some dissipation of the prior contrast that was seen.
I mean, the pattern of hemorrhage is interesting. There are several foci. It seems of parenchymal as well as subarachnoid blood. Right here, there's a focus. Up there are 3 parenchymal foci, to me.
Mm-hmm.
Plus the subarachnoid.
At 36 hours, this was a CT scan. So it was grossly stable. So the patient was managed medically. By day 3, he was back to his normal self with a normal exam, the aphasia resolved, and then he was transferred a day later for surgical resection of the AVM. So the reason I wanted to bring this case, obviously, is for all the points that were mentioned and to have a discussion about this. So first, regarding the decision, regarding the choice of the feeders to treat initially, and then the decision to conclude the case versus continue, regarding the stage treatment versus would you treat, if you want to do that endovascularly, would you do this like on the same day, on the same admission? What do we think caused the hemorrhage? Was it something in the procedure? Was it post-procedure? Was both? And how could we have prevented the hemorrhage? Any comments on the devices that could be used and what could have been done differently? And thank you very much.
Thanks, Ram. I think some of this was discussed already, right? To some extent. Yeah.
Okay. So cases like this are exactly the cases that brought us to stop doing endovascular curative treatment of AVMs 15, 20 years ago. Why? Because we had plenty of hemorrhagic complications due to both aggressive treatment on vessels, pull of the catheter, retrieval of the catheter, but also changes in the flow inside the AVM following the treatment. So venous occlusions, even if you don't see anything in the veins, that they can occlude and so on. So thank you very much for bringing this case, because it brings me back to my youth when I did things that I then decided not to do anymore. So this is a case which is very easily treatable both by surgery and by radiosurgery. I don't think it should go to endovascular treatment, even if some people would do it. I don't think you should use glue for the same reason, because you can glue some of the feeders, but then there are plenty of other feeders which will come out once you glue the main feeders. Main feeders mean that there are lesser feeders everywhere. You will always find some other feeder unless you occlude the vein. But if you occlude the vein, you run the risk of the occlusion of the vein. We have seen that many times by the arterial route. So you go to the venous route. Venous maybe would have been a choice in some places, and it's probably, for me, much better than any arterial access to this AVM. So you have to occlude the vein. You don't have to stay away from the vein. And the other thing is the staging. Why the staging? If you have to occlude, you have to occlude immediately and everything, because if you leave something, that something will rupture and hemorrhage. So prevention of the hemorrhage is, first of all, not doing these cases. Second of all, doing everything with probably detachable tip catheters and occluding the whole thing in one step. But probably, again, I don't want to be at all accusing or being insulting, not at all. I'm just trying to say that things have gone forward in the last years, and probably in the world, we should decide that some treatment should not be done anymore.
Thanks, Dodi. A couple of people raised their hands. Fabian and Fang.
Yeah, so just short. So I agree with the Dodi on it's a good case to show because it explains the reason of the outcomes of the early days of AVM treatments. But I just want to continue to say that first off, I think this AVM I did not see a sign of imaging wise of a bleed, and it's a very good case for radiosurgery. So probably would have been our choice. In the case of a bleed, I believe it's also a good case for endovascular embolizations. But the techniques that we use today is very, very far from this, what you showed. And there is a significant evolution of techniques of embolization of AVMs, where I think we have come a long way. But I think it's too much to go into here right now. I just want to say that there's a lot of things have happened since the techniques on display today. To go by the MCA and embolizing to control inflow, of course you can do that, but in this case you're exposing the anatomy to a lot of risk. You with the headway duo in this territory, wire perforations, catheter perforations, artery avulsions from pulling, it is not the tool that you want here. And also pushing the material in this way, it does not give you more than just putting coils here, more or less. So for me, it would be to go here and maybe do some NBCA work before occluding the AVM from the largest artery, and maybe also from injecting by the vein in a sandwich technique by detachable catheters and pushing it. So and also another key part when you approach an AVM is that because you told during the presentation, you said, oh, maybe there was some other feeder, so exploring and knowing exactly which feeders are feeding the AVM before you start embolizing is very important. But yeah.
Thank you. Yes. So which catheters would you have used, like a detachable microcatheter?
Yes, for filling the AVM with Squid 12 would be Apollo or Sonic, depending on, and by using pressure cooker technique, or some people are very comfortable using balloons enabled to fill, but you can absolutely do some work approaching indirect feeders by the magic, putting some glue or injectable coils at some places. Yes.
Yeah.
Fang, you have some comments? Unmute.
Hi, everyone. I have some questions. First, after the procedure, did you reverse the heparin?
No, we don't usually reverse heparin.
So also, I think if we see the bleeding, especially in the sylvian fissure, it's distal to the nidus, so it should be the most frequently caused by the destruction radars after the when we pulling back the catheter, and heparin will make it worse. So I think control blood pressure is important, but reverse the heparin with protamine is quite important in this case. Otherwise, maybe the patient can be neurologically intact after the procedure. And for the strategy, the detachable coils, I agree. And another concern is it routine to use a 38 DAC in this scenario? So I mean, the distal access catheter, do we benefit from the use of this catheter?
You mean using something else instead would be better?
It seems like usually we can go directly with the microcatheter to position with the proximal, like 6 French or 7 French. I don't know. So what's the concern? I mean, you use this intermediate catheter, what can we benefit from it?
Oh, yeah, I thought because we needed some form of intermediate with a guide catheter being in the ICA to get stability distal enough, close enough, I would say, to the AVM, and distal enough from the ICA. So yeah, we thought that maybe the DAC was small enough to fit into the MCA. So that's why we opted to use it.
Fang, I would say this, that of the many, many things that I disagree with this case, this is one of the ones that I agree with. I think using the DAC or some sort of intermediate catheter actually helps with the pool, and to the extent that the pool was traumatic, I think without the DAC or something similar, it could be even worse. So I would consider doing that,
I
I
think
do
the
think it
DAC
helps.
becomes a limitation if you have to use if you want to use multiple microcatheters. But
Exactly, that's my concern.
yeah, but he didn't use, right? So that's the thing. Like if you plan to use one, I think it's actually helpful.
Rene,
one,
no,
what do you say?
Yeah, go ahead.
No, one thing is after this if we have such a problem, right, after AVM embolization, we would bring back to the angio suite to understand. And I'm not sure if you discussed that or not, but like there could be something like going on, and indeed, like it kept worsening for a little, even if the story ended up being good at the end. Is it something you considered?
Okay.
Okay, Rene?
Yes. So thank you for showing a case, because showing problems is not what we like to do. So that's great, because we all have a lot of things to say. I think that this AVM is a very simple one. I'm sorry to be rude, but it's not a complicated one. I think that we are far away from the techniques that we use today that are very different. Which means before going into it, I mean, at times of propulsion chambers in the 80s, it was heroic to bring a microcatheter inside one feeder. Today, it takes a couple of seconds or minutes. So I think it's mandatory not to go inside the easy one, but first to check all the arteries. Because at some point, whenever you start to feel what you see, and what you see is only a part of the AVM, you may occlude one primary vein and you're not able to understand it. Which means, first of all, check all the arteries. And then there will not be 120. There may be 4, 5, 2, not more. So you will see which are the obvious ones and then the difficult ones. So if you're in the easy one, you may hope to push your embolic agent in the difficult one, but it may not work. So the whole thing is to know what I'm going to do when I'm compromising something or the vein, and then I need to do more. That's why it's so much more logic to start with a difficult vessel, so that you can always do the easy ones later on. That you should not disconsider at this point. Then, in terms of understanding, knowing the arteries is a good thing. This AVM is to be treated in one shot by the vein without any doubts. But before doing it, you need to place a couple of microcatheters in the arteries to control what you do. Whenever you do a run by the guiding catheter, you see a little bit, you miss a lot. And all what you lost is micro information by the microcatheters that tell you if this feeder is giving a transmedullary artery which is occluded or not. And even if you do these efforts, sometimes it's not enough. But you need to have all those efforts done and considered. But how to do this without doing imaging of the AVM itself, what I call 6D, which is put a couple of microcatheters in the MCA, make a 3D from there, put a couple of microcatheters in the ACA, put a 3D from there, fuse with other colors, and you will see a lot. And then you will discover a lot that you did not understand before, so that you can understand what you do. So of course, problem happens. Of course, bleeding happens. But from a systematic point of view, whenever you treat an AVM, what you fear is bleeding. So as a systematic rule to bring down the blood pressure, you told us 130 blood pressure is a lot. We put systematically 20 below the normal blood pressure, knowing that the normal blood pressure is probably a bit less than what he comes in with when he arrives in the OR. So all those are things that certainly help a lot. And of course, I do agree with Fabian started to open the door, but not only to the question of why to stop. I mean, because you must have a rationale from the beginning to say, okay, I define this compartment, I want to do this, But then you must be quite sure if you push from the artery to the vein, that the vein that you start to fill has no other arterial feeders. And potentially, if it bled from the AVM, I'm not sure, because while driving it's difficult to look at the picture, so I did not look at it. But it may be something like this. It may be also because with a non-detachable tip catheter, I mean, the Headway 17 or Duo is a very good catheter, but not for AVMs. I mean, it's complete out of the range. No microcatheter having a wire more than 10, 8, 7, and soon 6 should be the wires to be used, because the CT you showed, having some SAH, I would say it's 50% of the AVMs. It's always that you got a little bit of something, but it does not mean that this bleeding will continue. So did you hit some perforating arteries while navigating with this, I presume, 14 wire? Potentially. Is it while retracting the catheter, which is still quite stiff and not detachable tip? Potentially. I would say rather this, otherwise I did not see the pictures to see if it's more from the AVM, but definitely a whole setup is required. But if those conditions are given, the chance to cure this AVM with a risk which is certainly not higher than radiosurgery, and radiosurgery in our practice is to go on for embolization. And probably transvenous is safer than transarterial, because before you go on for transvenous, you first secured or controlled or checked all arterial feeders to know what you need to do.
Thank you very much for the feedback and for all the points being made. And that was one of the reasons why I wanted to bring this case, because for me personally, there was a lot to learn from this case, and presenting it in front of you all was the goal, to gather as much as possible feedback for the future. So I appreciate that.
Thank you again for showing this complex case. Thank you, Rami.
Rami, thank you. Yes, thank you very much.
Yeah, thank you.
Excellent. And the discussion, I think is very worthwhile, and extends very much. I think very much like what is important in this discussion is that there's so many differences in technique, but there's also so many differences in material that we do or do not have available in different countries here, for example. So it's very insightful to see what can be done and what we have, and the differences in how AVMs are seen, which is probably the widest range in terms of experience and tools, is the disease this is the disease where we have the widest range of everything. Okay, Rene, can you are you good now to
Sure,
show your?
I'm perfect. So let's share this patient here with a very unusual situation, which is the following. This patient here she's not young, she's in her 70s something, so 75, I would say. And she got this symptomatic extradural aneurysm. It's symptomatic. She's reducing what she does. She has diplopia. Whenever she stands up, she is limiting what she does. So her daughters are very pushing for treatment. And I mean, why not? It's an extradural aneurysm. So, okay, we go on for it. Here are two threads that are put in a telescopic way, because the first one was a bit short and somehow landed, and it was done for someone of the team who made it, I think, very properly extending. Do we have a proper wall position? I would believe that yes, at least some significant efforts were done, and then a catheter was jailed. Some coiling is being achieved. This is the end result. And a few months later, I mean, the fact that the other aneurysm is irregular, is not large, you don't know really. She's on dual antiplatelet, but of course, this won't make her bleed. But okay, is it bilobulated? It is a reason to do more. And at some point, there's a willingness to treat this aneurysm. And the person that does it crosses simply and tries to go and push, and somehow it's difficult. And finally, this person, I mean, it's difficult to get access and it does not work. So the aneurysm is left like this without seeing that the stents are somehow displaced proximally. And I'm sorry because I cannot offer you pictures showing this. Oh, yes, I can. These were the pictures initially, you see, where the flared ends of the thread are proximally here. And here you can see that they are not there anymore. So this was overseen, but trying to access the ACOM was difficult, and then it was considered that it was safer not to insist without seeing that it was at least 2 months after the first treatment that the flow diverters had been displaced. And then we said, you know, it did not work, and we prefer to leave you alone and not to go on with it. And then she goes back home, and after 6 months to 1 year later, I got several emails from the daughter saying she's having again symptoms, and her symptoms are increasing, and she's not so good. And in fact, she stopped doing what she does usually, because as soon as she stands up, she's got diplopia and the headaches are increasing too. So what's going on? We do an MR showing that the aneurysm is growing. I'm sorry I don't have it here. I prepared this this morning, and I realized I don't have the MR, but you must believe me that the aneurysm is not thrombosed. It's growing, which is not so surprising when you realize that the flow diverters have been displaced. And the idea is to do something. So what to do? I mean, parental artery occlusion is not such a bad idea. Knowing that first some attempts were made to go through the stents, and after 1 or 2 hours of attempting, it just did not work because the stents have been pushed inside. And given the fact that there is a strong clinical discomfort, which I agree this is not shown by the pictures, but there's a strong willingness to do something, you say, okay, why not doing an occlusion test? And we do an occlusion test. And the occlusion test shows that ACOM is very good. I mean, it's fine. It's not perfect, but there's not a long delay in between the veins. I would say not more than 3 seconds, maybe 2 seconds, hardly. So it seems to be okay. She's sleeping, so we don't make the occlusion test while putting her awake. We consider that it's fine. But on the other hand, if we occlude the left ICA, I mean, there's this aneurysm, and the flow increase through the ACOM can only make the flow increasing, and it may be an issue. So before occluding the left ICA, we go on for coiling of that ACOM through the left side, and this is here the ACOM before, no stent, because if you've got an in-stent stenosis, it could be any issue. So the aneurysm is coiled like this, and we consider that it's enough. We don't stent. And we say, okay, next time, once we're sure that we don't get any thrombus extending here that may compromise anything, we'll occlude the left ICA. And anyway, I'm not sure whether we considered occlusion of the left ICA. So we want also to explain her that we did not succeed in getting through the left side, through the stents, that they've been displaced. We were not aware before. So it's quite different from the plan we had, and we did not inform her about that. So we need to do it this way. So the aneurysm is further growing. Maybe you can see here the coils are displaced, and we take her back a few, I don't know, a few weeks, or I don't know, 1 or 2 months later. And before occluding the ICA, the left side, we do another occlusion test to make sure that nothing changed. I'm not aware whether it's common to do repeated balloon occlusion tests. At least for me, it's certainly not a frequent thing, but this is what we do. You may see that the balloon is inflated here. I hope that you can see it. And we repeated it, of course, 2 or 3 times. But look at this. The ACOM is gone. I mean, there is a little ACOM, but it's just gone. It's not the same than it was before, and the question is what to do now. So if we look here, we may see that it was a bit narrowed. So did we do any trauma while getting inside with a microcatheter? Potentially. I mean, even if we did not see it, it's not because we don't see it that we did not create any issue. But now that we intended to occlude our left ICA, the ACOM that was existing is not there anymore. So maybe we can discuss at this stage any similar experience.
I'm sure you got some higher, like more focused images on the ACOM complex there. Just to understand, I mean, what to do, okay, we'll think about it. But, you know, here, like, is it just thrombus that form at the level of the neck of the coil? Probably that's the thing that would make sense.
So no, this was the appearance, the A1 which comes from the right was at the beginning of treatment. We have some 3D which was similar, and after treatment on this projection, we see it a little better that there is a little narrowing. So this is not a clot that was
No, but
and not at this stage, but later on, I don't know. I mean, we stopped the procedure here. Patient was fine, had no stroke, went home and came better, has still her symptoms because of that growing aneurysm in the left siphon, but nothing more. So was it some clot that grew out of the aneurysm? Potentially. I don't know. But we took care not to overcoil. Maybe, I mean, yes, there's one loop here, but we did rather less than usual to go to the very end of the neck because we didn't want to stand here, being afraid of having some instant stenosis.
I mean, the clot would have to be in the left A2, A1, in order to have
you're
this
right.
appearance.
You're right.
So,
It's more A1, A2 left.
I mean, for me, I could have a theory here on flow, and that is that on the left you have a quite large aneurysm, and large aneurysms cause a pulse pressure drop, meaning that a growth of this aneurysm would lessen the contribution from the left side, promoting an ACOM, right? In a previously from birth dominant left A1. So when you occlude the aneurysm or you reduce this circulated sac, you provide another pressure gradient, which means that the ACOM is not needed anymore in the same way, which makes it regress. But yeah, that's maybe complicated, but what we see is the dynamics of the communicating arteries is incredible, and the more you work, the more you see. And you can see an increase of triple the size of a PCOM in just few weeks. I don't know how long this takes, but
So,
I
yes,
think yeah.
Thank you,
Super
Fabian.
important.
It's exactly what we were considering, maybe less cross flow and maybe less demand, and that's why shrinking of the ACOM. But at this point, I mean, just look at how the occlusion test was. It was good. And then you see nothing. I mean, just faintly, but so few. And of course, we repeated it a couple of times to make sure that the balloon was properly inflated, not that we're missing here a flow coming from the left side.
I assume you also did an injection from the left at this point.
Yeah, absolutely.
That looked, and I guess you have a good A1, correct? On the A1, just
yeah.
But we are discussing what's the problem now and what we should do now. But I would like to say what we shouldn't have done before.
Please.
Because everything was going very well for this poor lady. How old is she?
70 something.
Okay, so everything was going very well for this poor lady until somebody decided that small ACOM aneurysm should have been treated. Leave her alone.
I fully agree. I fully agree. I don't, yes, I think that the stent was pushed by trying to go through again, but which shows also, and I think that the message here, I fully agree that one message is to say not to treat that other aneurysm, but one message is also to say that the stability of flow diverters, even after a few weeks, I would have expected here that we would have more stability and that they would not displace,
Yeah,
which was
but
not the
I
case.
disagree with that because this is typical of this kind of the thread, which has the flares. It's not
Yeah.
exactly the whole. So it's very easy to go through the flares of the thread, while it would be almost impossible to go outside another flow diverter which is well opposed. So
Which means that you stop the thread in your practice?
I've stopped my practice, but
No. To this
but if I
question.
have to, I would I would be very anxious to go back again inside the thread. That's why a telescopic thread construct is very risky to do, because you might have to go through the flare before entering the first stent, and so you place the second stent through the flares. I've been saying this many times because it happened to me, and so that's why the thread is much more complicated to go through with a new catheter once it's deployed, unless you, yeah.
No, I agree with you. The thread is not a good stent for telescopic. We did not have good result for telescopic. I must add here that I think that when this aneurysm was treated, it was not the goal of the person who treated the patient to have a telescopic. It's just that the choice of the thread was a too short one, and it moved, and it appeared not to be the right choice. So this aneurysm is not that large, and one long one would have done the job, but one long one is also the problem of not opening properly. So, but clearly it was not our intention to telescope here.
I mean, the other point is to be critical, not just the thread, but the big problem here is the coils. The coils don't allow the person to then see what they're doing in potentially in crossing to go back to the ACOM, no? Like most of us
You
would
mean
not coil an
coiling to not be
aneurysm
done?
like this.
Oh, really?
How many people coil a cavernous aneurysm, that presents with mass effect?
Never.
I'm not
Even
sure.
very giant intracavernous, you don't need to coil them. It's not the same as intradural. No.
I mean, sometimes there are sometimes we are concerned that there is some erosion of the extension into some like outside of the cavernous sinus. That is valid concern. Here, it seemed like the aneurysm was not of this type, but I mean, personally, I don't think many of us would have coiled it.
But okay, if you show a case of a flow diverter that does not work, then the comment is quite often, why didn't you coil it? Because it would have potentialized the thrombosis.
I mean, yes, that would not be my comment. My comment would be use more flow diverters. If this is a puff aneurysm, put in 3 pipes, and the probability of cure is very high. So I would push. I mean, that would be my take on it.
Rene, a
Tibor
question.
has a hand. Tibor.
Yeah,
Tibor.
Rene, I have a question. Yeah.
Yeah, go ahead.
Yes, since last time you performed you tried to coil the ACOM, and then you noticed that there is a displacement of the flow diverter. Because the microcatheter has successfully passed through the flow diverter. At that time, why didn't you consider put the third flow diverter?
Because the goal was to treat the other aneurysm, and continuing to push on the microcatheter to get to the ACOM aneurysm was the reason why the operator pushed the flow diverter in the aneurysm, and this was not seen. So the focus is at another place. The flow diverter induced increased friction. So of course, once you're inside, you can do it, but you need to see it. The focus was another one, and getting from the ICA to the ACOM was not so simple. And obviously, the operator trying to push the microcatheter further inside the artery led to proximal issues without further displacement of the catheter.
But at that time, did you focus? Did you confirm that the microcatheter has been in the true lumen of the flow diverter?
Yes, because the first crossing, from what I heard, was very simple.
But why didn't you put the third flow diverter at that time?
So you did not get it. The diagnosis of the displacement of the flow diverter was not made during this procedure. Okay, so there was an attempt to treat the aneurysm. The attempt failed. The operator said, I stop because I cannot do more. And then because of ongoing symptoms related to further growth of the aneurysm, the patient was asked to come back with the idea to cross the flow diverters to add other ones. And then understanding was made that the flow diverter had been displaced. Okay, several months later.
Rene, is the patient on dual antiplatelets now? Do you know what the status of that is?
And all checked to see whether it's efficient or not. So yes, and furthermore, with displaced flow diverters, certainly yes. And we do systematic testing.
I mean, one question would be if we wait and maybe could it be that the ACOM could reopen at some point? At least reopen enough that maybe would allow you to go retrogradely through the ACOM and then back down and then come down through the thread that way to then enable to put in something else.
I think that's an option. I think that's certainly an option, but okay, it's hypothetical, but it's an option. You expect the flow to reduce in the ICA, and by reduction of flow we need the Silverstone clamp. We need to be able to reduce the flow progressively in the ICA on an endovascular way. This will help us in a lot of situations.
Okay, we have Tibor raised your hand. Tibor, are you there? All right, Guglielmo also raise your hand. Guglielmo?
Unmute yourself, please.
Thank you.
Rene,
I'm unmuted, sorry.
Yeah, go ahead.
You, Tibor. Go on, Tibor, please.
Yeah. So just sorry about that. So there's so much discussion that happened since I raised my hand. The only point I wanted to make, I think, is that ACOM. I understand it's a small ACOM and she's 70 something. It's not a good looking ACOM that I don't know if I would be comfortable leaving it alone. I mean, I don't know. I kind of feel the operator's sense of need to go to treat it. And I understand that the A1 was bigger on the left. And yeah, I don't know what's the right timing of going through a flow diverter. Certainly, I never used the Fred, but even a pipeline in a very large aneurysm with a wide neck where it's a long segment that is unsupported. We understand that, it's easy to displace when you put pressure on it until it's completely healed, right? So, yeah, I don't know what is the right amount of time to wait before pushing through a flow diverter construct like that. But certainly you have to be very cognizant of especially if you have an unexpected amount of resistance that you may be displacing the construct. And the other point I wanted to make is about the coiling. So I fully agree that in a cavernous segment you may not want to coil. I kind of have changed my practice since I've been out of academia and since the one and done mafia has raised this ugly head. I tend to what I call coil supported flow diversion is my practice in paraclinoids and stuff like that when the aneurysm is somewhat sizable, or PCOMs, because I feel like, if you're not going to use the old technique of multiple flow diverters, as we used to use, or I used to use, then I don't want to play the game of, okay, let's do an angiogram in 6 months. Oh, it's not done yet. It's not finished, but it's shrinking down. So yeah, let's keep you on dual antiplatelets for another 6 months. Let's do an angio. It's almost there. So I don't like to play that game. I like to tell the patient, okay, we're done with the procedure. Your aneurysm is gone. In 6 months, we check an angio. If the stent is looking good, we take you on the dual antiplatelet and you're finished.
I mean, I thank you. This is my thinking also. I mean, if you look in the literature, the efficiency of flow diverters is quoted to be something at 70 to 70+%, which means not so much because it depends so much on the selection of aneurysms. But I mean, if you want to see it on a balanced view, coils enable to potentialize the thrombogenicity and to increase efficiency. But they do not enable you to see what's going on with the stents that are in place. So we have both disagreement, and of course we all have aneurysms which were treated with flow diverters alone that recur, and where you would like to go inside and to add coils, and you just cannot. Concerning the ACOM, we thought it was a small one, monolobulated, so we were not excited in treating her. And then when we saw it on the angiogram, while treating the first aneurysm, we said, oh, it's still more ugly than what we thought. Okay. But I think that's life.
Rene, for this case, any relevant PCOMs or no?
So now,
Guglielmo?
Guglielmo, you change your mind?
Rene, sorry. When you shown the last situation where there is no more cross flow, we see the left A1, I think. Is it correct or no? In the Zoom image.
I don't know, hardly. No. The Zoom image was at time of treatment of the aneurysm. This is a balloon occlusion test number 2.
Okay, and in this kind, we don't see the left A1. Yes.
No.
Okay. And sorry, another thing. Did the aneurysm, the intracavernous aneurysm changed? Was more thrombosed, something?
It's growing. On MR, it's larger. I always take all images of angios on my laptop, but not the MRs. It would be too much. That's why I'm missing it.
But the flow is better or worse?
No, it's growing. She's more symptomatic, and on MR, the size is larger.
Okay.
And Rene, you tried to then go back through the thread, and right? It was after in the follow-up procedure.
I tried to go through the thread, and no way. I mean, you just end up in the aneurysm and you don't see what you do. So if you don't see what you do, trying to go through more, I mean, after a while, you know that you will create some mess. And you will occlude it unintentionally.
Did you consider to go through the ACOM below in the left ICA?
So I'm going to show you what we did.
Yeah.
Which is given the fact that the artery is there. Okay, it shrunk, but it is there. We just don't see it. But is it gone? So I looked at it on a magnified view, and this is what you see. You still have that stupid thing here. Is it clots? I mean, she's on the dural antiplatelets, but I don't know what it is. And if you know that it was good, I mean, I would not treat a hypoplastic. But if it's not a hypoplastic, but just a vessel which is shrinking and changing, I decided to go on through stent PTA. And I went through. I first took a small balloon, looked how it was, and then I put, I don't remember the size. And then I put a 2x8. And interestingly, after, by doing the test occlusion, we had a nice test occlusion. So because of the variability, I mean, without having, of course, the knowledge of the previous balloon test occlusion, where you saw that the artery was wider, I wouldn't have done it, because you cannot PTA a hypoplastic artery. You would just potentially burst it. But if you know that it was larger sometime before, we gave it a stent PTA, and then we occluded the ICA.
This is the same you do with the AVMs when MCA occlude spontaneously.
No, I don't stent. I don't stent because I think that recanalizing a stent is more complicated than recanalizing a native artery. But okay, the number of patients is too low to make any statement. But I mean, I've never been doing this, and I thought because we had the information that the vessel was different before, then there is some plasticity, some elasticity, sorry, and which was confirmed.
It's a great case, Rene.
Great.
It's my question, I guess, would have been then what I was asking before. Like once you stent this segment, is there potentially reason to try to retrogradely go through the FRED and preserve the left carotid if you can? Should there be an issue with the stent? Or is that too much? It's too better just to close the artery and keep it simpler?
So, I mean, keep it simple is maybe not exactly what we can say here.
Yeah, exactly.
Maybe doing a PTA and then doing a PTA with the stents, trying to go through. I mean, I did not want to treat that patient. And when the daughters called me back, I said, oh, it's okay, it's not so bad, until I realized that the stents were displaced. But there was a strong demand because they told me clinically what was going on. She was afraid to stand up. She was just sitting on her chair doing nothing and functionally losing her independency.
Yeah, no, I'm not. I support the treat.
So,
I'm not saying not to treat.
No, but because of this, then to make it, I haven't seen many situations where this have been done where the outcome was clinically good. I've seen a couple of heroic save of the ICA, but at some point, some complications occur. So I thought if we can treat her like this, because even if you put a flow diverter or two, the displaced one, how much are you going to replace him properly? How much is the whole construct going to work properly? I mean, the best treatment of an aneurysm, best ever, is to occlude the artery. This is what we want, and leave her alone.
One obvious concern that I'm sure you went through your assessment too is like, what's the underlying condition that caused this stenosis occlusion, and how permanent will this stent, this balloon mounted stent, I guess, placed there to keep this open?
I mean, there are two things that were done, which is not only stenting, otherwise I think that it may have occluded again, but stenting and occlusion of the ICA. So there's an important request
Flow
which we
demand.
had to take off. I mean, all those occlusions are potentially related to a couple of platelets that feel comfortable there, and then a couple of others come, and then they make a party, and then more and more platelets go there and have fun.
Right.
And finally, the vessel reduces. What should it be?
Yeah, except that if this stent closes, the patient dies, which it's not always the case. So I think that's what adds.
True. But I mean, the fact that you open the artery means you open the flow on a so much more significant way that the chance for the platelets to feel comfortable there to do a party is smaller. I mean, this was the expectation. As far as I know, she's doing fine. The MR is also good here. We did not induce DWI lesions. But okay, we'll see on the follow-up. I expect still that from the other solutions. And anyway, what else? Make her bypass?
No, I'm very supportive of the endovascular approach here. I'm just thinking about, and I get the reason of the timing, but, going back to what we were discussing, is an option here. Okay, we recanalize, we open it. Okay, let's keep the ICA open for a little until like we make sure. But whatever, it's just a different. I get it. You explain why you wanted one treatment and so forth. But I think that staged approach would add a layer of safety.
No question, Rene. Like what you recognize, but what you show, like the reopening of arteries that don't seem to be filling angiographically, but it doesn't mean that they're not there, right? That's a very, like you've been showing this for some time, and it's a very important lesson for all of us because so many more doors to open in all these cases, right? So based on that, now we have more questions.
Yeah, I think it's to realize how much hypoplastic vessels are. I mean, the vessels are living. Vessels are developing, creating, involving. Hello, Doddy, and a lot of things are going on. And if you consider the dynamics which are behind, somehow it may stimulate our willingness to make more out of vessels that are not good, but that we can develop so that they become good.
Yeah. And I mean, to push that more, like I would say that regarding the philosophy of flow diversion, that's one of the harnessing, right? One of the success of that is to recognize how we can remake vessels and how we can shift territories and use that to our advantage, right? So I think that sort of indirectly plays into what you're saying.
Max.
Yes, Tibor.
My thoughts are swirling. This is such a fantastic case. And Rene, hats off to you for doing this. And it reminds me of something. Once Pat Kelly had a publication about his posterior approach to posterior thalamic tumors. He was publishing a series of cases, and in the end, he put a disclaimer. And this disclaimer was something like, "Don't try it at home, kids." Okay, this is that kind of case. It can be done, but you shouldn't try it in your own lab. This is the kind of case. The other thing is I totally agree with, okay, once you go for reopening that ACOM, you have to shut down the carotid at the same time, because it's kind of like doing a bypass and then not shutting down the vessel that you were targeting to bypass, right? Then the bypass is not going to live. So the only thing you lose by trying to give a chance to see if your bypass is going to work and not taking off the parent vessel that you were targeting, right?
Mm-hmm.
So, and the third lesson is don't use Fred.
Okay, I've got nothing against Fred, but here it was not so good.
Rene, it's a fantastic case of opening these roads and the collaterals being more and more coming into play now. Treatments. One thing I'm considering here, the safety of inflating a balloon in a vessel that we're not sure on. Okay, you knew it from before the size, but do you think we could have other tools to try to make this a safer test? For instance, do you think it would be to open the Comaneci device? Would that potentially be less risky? Because of course there is a risk of inflating a balloon in a vessel like this. How to I mean, with your experience and intuition and everything, this is another thing, but this is potentially a powerful tool for some very hard to solve aneurysms. But for myself to inflate a balloon in a vessel that I'm not really sure, maybe there is a more cautious way. I don't know. Do you think?
That's a super idea. I did not think of the Comaneci. I never saw Comaneci rupturing a vessel. I think the Comaneci has a low force and would not do it. I mean, using compliant balloon probably makes no sense, because if it's compliant, he will open where there is no place. So I'm not sure it would have been good. At least the Eclipse 2L is more compliant than the Scepter XC. So I don't think so, but the Comaneci is a good idea. Okay, let's see if there's going to be a next time. Not sure, but to make a test with a Comaneci would be a good thing.
Okay. Thank you, Rene.
Okay.
Super. Let's see. We are, of course, try to stay on time, but we cannot help ourselves. If maybe one more case we could do, if Bright, if you can hear us.
Yes, sir, I can hear you.
Okay, great. Go ahead, please.
Can you see my screen okay?
Yes, we can.
All right. So, first of all, thank you so much for the opportunity presenting the case. Here, my name is Pichatorn Suppakitjanusant, but I go by Bright. I am third year resident at Texas Tech University in Lubbock, Texas. And today we're gonna talk about the ethmoidal dural AV fistula. Let's get it up. All right. So the case presentation, this is a 65 years old male with the pulmonary history of seizure, mood disorder, and hypertension, presented for breakthrough seizure and altered mental status. He complied with the home anti-seizure medication. He denied history of trauma, and from the neuro examination, just altered mental status. The rest of exam was unremarkable. So we did the non-contrast CT head, and it's also unremarkable. When we do their CTA, we found opacification of the enlarged and tortuous vessel and mass in the anterior fossa, as I mark over here in the sagittal axial and the coronal plane. We did MRI and we kind of find the full void in the T2, and then kind of like in contrast enhancement in the T1 post contrast MRI in the same area. So we think likely this is the high flow vascular malformation. Not sure is that AVM or dural AVF yet, but look like from the location likely dural AV fistula. And so we did angiogram to see and know learn more about what exactly this lesion is. So this first angiogram, this is the right ICA injection, AP a lateral view, and then as you can see over here, and this is the oblique view. So I kind of mark it down over here in terms of their structural identification. So first of all, look like we found ethmoidal dural AV fistula with the feeder from the ethmoidal branch of ophthalmic artery. And also the draining look like it is the cortical venous drainage, and we also found venous ectasia. From the AP view, there's something that a little bit concerning. There is the secondary venous congestion. I'm not entirely sure this is the basal vein or through the cavernous sinus, but maybe look like more basal vein. And then
Sorry to interrupt. What do you mean by secondary? What is secondary venous congestion?
Like a flow, maybe like the drainage, like drainage after the run to the other side.
But it's still drainage of the fistula. It is the
Correct.
fistula that is draining there, right?
Yes.
And
yes.
because we're still in parenchymal phase in the ICA. So, I mean, based on this lateral, that seems to me like, deep. You see that there's an orbitofrontal veins on the lateral, on the image in the middle. So I think that's just another outflow of the fistula.
I see. Okay. Yes, sir. Thank you for the comment.
No, it's just based on these images, that's what I would guess. But it could be. I don't know if anyone has other opinion about this. But all right.
I can go back to this AP as well to see the flow better.
Yeah, you see, it goes. It's that orbitofrontal vein. You see that, like you see opacifying pretty early and going back, and then it's superimposed on all the vessels, so we don't see exactly the relationship. But yeah, this looks the basal veins.
I see. Thank you, sir. And then so we also did the right ECA run injection. So we also found that there is another feeder from the ECA on the right side, which is the septal run of the sphenopalatine artery. Over here, this is AP and lateral. And
And you
then
can see all the veins that Eitan was talking about. Now you can see them much better in the lateral view because the carotid is not superimposed, right?
yes, sir. Then we do the left ICA injection. This is the AP and lateral. This is the oblique view. So still, we also found that there is the another feeder from the left side, which is the ethmoidal branch of ophthalmic artery as well. And this is the ECA, left ECA, which we also think there is another feeder from the left septal branch of sphenopalatine artery as well. So I put both of their run, compare each difference view, and to summary, look like these fistula have feeders from bilateral ethmoidal branch of ophthalmic artery and bilateral septal branch of the sphenopalatine artery, which actually the right more than the left, and then drainage to the bilateral frontal cortical vein into the superior section of sinus. So after this admission, a patient has followed up in our clinic a month after. We discuss, so the seizure has already been controlled by medication. And then we discuss about the patient about the risk of this fistula to the patient, giving there is a cortical vein drainage and also a venous ectasia, which is the Cognac classification type 4. So we also discuss with the surgery team as well. So they say that they like up to the patient, we can do either surgery or endovascular approach. And then we talk to the patient and family choose to do the endovascular embolization treatment. So a month after we schedule procedure, which we did transophthalmic to the right common femoral access, use the Neuromax 088 as a guide catheter, Phenox as an intermediate catheters, Marathon for the microcatheter, hybrid both 008 for the micro-Y, and we did onyx embolization of ethmoidal dural AV fistula from the right ICA. So this is the treatment, how it looked like from the right ICA, AP, and lateral view. So we didn't get the native view post-treatment of this time, but spoiler alert, we did like the second state of the treatment. So we kind of capture how the onyx like location that we place in, which is over here, and this is a zoom in over here. And after this treatment, we run the rest of the vessel, and we kind of surprised. And this is the left ICA post-treatment run. This is left ECA. So a little bit of surprise. We see more prominence of the other feeder in terms of the look like more in the right side ECA. MMA collateral feeders more prominence compared to the pre-treatment. However, good things, we still preserve the choroidal blush, which patient also doing well after procedure. He not losing the vision, no seizure, and doing well. So this is also the left side. We feel like there's more prominent feeders on the left side as well, both ethmoidal branch and also the septal branch. So in conclusion, the onyx didn't get into the common collector, so the treatment is not curative. So still have remaining feeders on the left ethmoidal branch, and then bilateral external feeders. So we ending up schedule stage 2 embolization a month later, which now we are think about the transvenous approach. So we do the venous access to the right common femoral vein and the artery access for the contour run for the left common femoral artery. For the venous access, we use Neuromax 088 for the guide catheter, and then we use high point tensing for the intermediate catheters. We use Marathon for micro catheters and Asahi 008 for the micro-Y. And then we did embolization with koi and onyx through the venous access. This is how the venous approach look like. This is the micro run of the fistula point. So ending up successful treatment. However, we unfortunately don't have the native view of the onyx and koi cast after treatment. So this is the rest of the run. So look like the fistula was gone. Patient doing well, no complication. He's able to discharge the next day, and then he about to have upcoming 6-month follow-up in the next couple of weeks for now. So in terms of discussion, I know that I read through the neuroangio website. I know that transophthalmic is not the ideal way to pick. However, because of this like challenging feeder, like bilateral, both like ophthalmic, like ethmoidal branch and also the septal branch, like I would like to hear from you all that if there are any things that we can like do better or anything that we can do differently. And then also in terms of the embolization agent or technique that could be discussed here. Thank you for your attention, and special thanks to Dr. Bushnak, Dr. Littal, and Dr. Nampon for helping me with the presentation.
Thanks. Thank you, Bright. Very nice. Okay. Questions, comments?
I have to say this is a very typical fistula in the anterior cranial fossa. This is my personal view, not representing all the common sense that I think the surgical approach will be the first, will be my priority. And because for this kind of cases, you can see that the controlling the outflow, I mean the venous control, will be enough for the treatment of this kind of cases. So maybe coronary incision is a very big, it's very invasive, but for this case, in the intracranial part, I think is less invasive, because for some of the I don't agree using this kind of using the ophthalmic approach because according to some reports from my Chinese colleague, if you use the arterial approach, there is some possibility that you will cause the patient blindness. So we will never try like this. But if we want to do the endovascular treatment, I think if I do, my first choice will be use the venous approach. I mean, the controlling because the fistula is a venous disease, I think. So controlling the venous, controlling the outflow of the fistula will be enough.
Now, back to your venous approach, you had you coiled and then you inject the glue proximal, or you did the 2 microcatheter sort of like pressure cooker? It was a little unclear.
I think it's more like a pressure cooker, like put the coil just to like help with the like pressure.
I think it's 1 microcatheter. You had 1 microcatheter, right? But you didn't have 2 microcatheters.
Oh, yes, right. Yes, we have only one.
So you put the coils and then you inject liquid embolic through the coil mass, essentially. You were not more distal to the coils with your microcatheter.
Yes, that's correct.
I think, it went well, so what to say, when things won't go well. But, that's something that, especially if you have a 70 catheter there, I think if you want to use this technique by coil and liquid embolic, I think I don't see much downside of like trying to have 2 microcatheters. Just it's a little note.
Yes, sir.
It's very helpful for 100 different reasons. Something might happen to 1 microcatheter, who knows? Or what if there's bleeding, that can happen too. The other catheter can save you many times, or whoever is doing the case. Yeah. There are a couple of questions. Fang, you have a comment?
Actually, I have a different opinion with Dr. Ni. I personally would choose endovascular procedure for this kind of fistula, and both arterial access and venous access. For my own experience, I can always take the fistula in one session, and our aim just to take it totally. And via the arterial access, it's the key point is just to control the onyx reflux, and biplane is quite important because usually when you have a complication, mainly it's caused by the onyx extravasation to the contralateral of milk artery. If you have only a monoplane, So if you have a biplane and we can control the onyx reflux, I think the arterial access is acceptable. Usually it's safe, but when you pull the microcatheter back, sometimes the movement of the vessel, the ophthalmic artery seems like terrible. It's just moved behind the eyeball, but seems like it's safe because even the movement of the artery is quite a lot, but we didn't have any hemorrhagic complication of these cases. But also for the venous access can also be an option. But I do have some venous infection after the venous access for this kind of fistula because when we because the vein is dilated, so when you even use a coil and onyx to occlude it, sometimes onyx can also enter the collectors, the veins who is collecting the frontal lobe. Usually asymptomatic, but there's some infection. So I don't know which way is better, but both can be used. And in my known experience, the clinical result and the angiography result are both quite good for these kind of cases.
Thank you, sir.
Yeah, can I just join on the technical aspects here? This is, of course, a neurosurgical case also, but surgery is not unfrequently complicated by anosmia, which is a handicap which is not insignificant. 10%, 20% of the patients experience this, and this is a straightforward fistula to treat. And for your approach, I would say if you go arterial or venous, take the one that's best. But for arterial, it's good to have double access. And why is that? So when you're embolizing, so you make sure that you do control runs to see if the shunt closes from the other feeders, right? So usually when you get the vein, you can be quite sure, but sometimes you're surprised. So I always make sure to have another catheter going around checking that all supply is done before I finish. And from technical point of view, arterial, the important thing is to get as close to the shunt as possible. To spend some time to get your catheter really up to the cribriform plate. Once you're there, it doesn't really, if you're really close to the shunt with a good position, it doesn't matter what you inject. So you can inject glue, 12, 18, whatever, and you will get the shunt. But if you're not able to get a really good position, I think it's a good idea to add a catheter, to put some coils, to pressure cook a little bit to get your stuff going forward.
Sir, thank you so much.
I think Tibor had some, I don't know if you're there, Tibor.
Yeah, I'm here, but since then it got answered. I have never been in the ophthalmic artery, and I know you guys at NYU have been, even though Kim trained me and he told me never touch the ophthalmic artery. And so I know you went back on his recommendation. And so in your experience, what is the safety there? And what microcatheter will you use here?
You're asking us, right, Tibor?
Yes.
I think, okay, I have a lot to say, but I think part of the reason we went sort of with Kim's prior recommendations and what we do now is I really believe that for one, like our tools are much better. So I think we can do more. We can see the anatomy better because we have high res cone beam that we didn't have before. So these, like multiple things are different. The third thing I have to say is I have like a kind of like a theoretical issue with not going into the vision is important, right? Of course. But like, is there something specifically different about vision than, let's say, language? Like we work with an AVM next to the language territory or next to whatever, all these other eloquent areas. Like this is another eloquent area. That's what I would say is like, how different, like how to judge what's what. So it's a risk benefit either way, right? Like as Wei was saying, maybe it's operate because the risk to the vision is, zero. if with surgery, basically. But there are other issues. So I don't know. I think we go into the ophthalmic for those reasons. Technically, I don't know. Like as Fabian was saying, I think many ways, right? But in terms of safety in the ophthalmic, the two things are to be like by the cribriform plate, as Fabian said, and to avoid reflux, right? Because whatever we use, if there's reflux, either we have to pull and the onyx or the glue comes back and then might get trapped somewhere along the way in the ophthalmic, or the pull itself might be injurious. So, you know, I prefer glue in these cases, dilute glue, but probably many ways to do this.
I think it's a great thing that you say, Max, because for myself, it's a cognitive bias. So the retinal, I mean, the ophthalmic is off bounds, but okay, we spend 4 hours in the anterior choroidal, we spend hours in the anterior spinal artery. We treat aneurysms in the ICA and spend a lot of time there. And so what's the issue here? But of course, I've seen a couple of complications with the central retinal artery. But
What kind? Fabian, you want to say what kind? And
yeah, so one involved a case where an attempt to treat this fistula with a septum mini was tried, and there was a reflux around the balloon, not much, but enough to make it difficult to pull out, and all the efforts to get the septum mini out resulted in a blindness. Yeah.
So it was the pull at the end. It wasn't the reflux itself. It was the pull that ended up being traumatic.
I'm not sure what it was in the end. If it was say excess saline with nimodipine coming from the DAC close to the ostium, DMSO, excess DMSO because some DMSO was injected to try to loosen the balloon. I don't know. Mechanical trauma, as you say, but
the retinal artery at the end was filling or not at the end of the case?
It was not filling, no. Or what? I don't remember. It was not my case, so I cannot all. But I was involved trying to help out. But so I would maybe avoid using a balloon in the septum.
So, but ultimately, what do you guys think as a group of people is that what is the safest approach to a ethmoid or dural fistula? Because I was in the operating room a month ago watching ethmoid or dural fistula from a small craniotomy, and yeah, the anosmia, yes, of course, that's a problem, but it was like a very straightforward case. And so I have one case coming up, and I thought about going transvenous, and it seems like it could be feasible, but I don't know, what do you guys think is the safest of transarterial, transvenous, or open surgery?
Transvenous here, you're going to essentially to a PL vein, and we've done it, and I think if it's feasible, it's a good approach. But let's not forget about the danger there. Never happened to us, thankfully. But there is a report on JNIS, a video report of a deadly complication from transvenous approach of this fistula. They try to go transvenous, and as usually is the case, like with this situation, if you perforate a vein, it's not a vein because it's an artery. Essentially, it's an arterialized vein,
right?
Like an artery. And if you don't have control of that, it can be deadly. So, I would say there obviously it's transvenous for getting to when you start to get to this PL vein, there are potentially risks. So which I don't know if it's higher or lower than transarterial, but something to keep in mind.
I think one factor is that the venous anatomy in these cases is quite, as any venous anatomy, like in this case, I think the transvenous approach, like there was a relatively kind of like not the tortuous catheterization. You could get to the venous pouch in a good way. So much so that I would have said, like, why didn't you could try vein from the beginning, right? So that's another point. But sometimes the venous anatomy is very difficult from the superior sagittal sinus, and then may not be worth it. So it is case by case, right? For sure. It's boring to say that, but it is like this.
I mean, it's also about how comfortable you are, and if you have not any experience in transvenous navigation, I think it's good to go somewhere and to see a good volume of how it's done. I mean, it's no strange thing, but for myself, I think before I did it, I went to see people who knew and had lots of experience, and I was happy that I did it. Otherwise, of course, the best way to the shunt is the most straightforward one, but you always have to, I mean, as in everything, to take account for what are your skills and strengths and comfortability, and all these ways together. And no treatment is free of complications. So, but if there's a straight way by the vein and you're comfortable by going by the vein, well, I think that's a good would be my first option. But
another possible route to get there is the middle meningeal artery up to the top and then coming down. And I think here you can see it on the third image on top with the external. Yeah. Can you see it branch from the middle?
Yes.
And then it comes down towards the other way, towards the fistula.
Oh, yeah.
Yeah. So we treated 2 or 3 fistulas like that from that route. You usually don't look at it, but it's finally possible, and there is no risk at all. It's arterial. It's the middle meningeal. You get to the fistula. You can inject whatever you want for as long as you want. I would never touch the ophthalmic artery.
You just said there's no risk at all. I will quote you.
In this position, because
you can cause an epidural hematoma, right? If you tear the middle meningeal.
Whenever, the risk of a middle meningeal artery embolization. I mean, it's always.
It's a good pickup. I really like what you said here. As much as it seems like a small vessel, it's probably catheterizable with a very small catheter, and it's probably the best approach ever. Because you're also occlusive. We did also a couple of cases. I mean, I think Max will show that one. I agree, it's by far probably the best way.
Am I the only one in the world who almost got in trouble with the middle meningeal artery?
And this is Eitan's case, actually. This is it, like this.
Yeah.
Yes, indeed. Now, but I will say, Dodi, I will say, like, people show cases of like MMA embos for subdural, staying like here, right? And there's onyx in the ophthalmic artery because of whatever, like, because of how this happened. So, yeah. But anyway, there's so many ways to skin this cat, right? So, yeah, that's on the website.
I think overall, though, like one of the things that I think evolved in my perspective of this, I think going through the ophthalmic is not anymore a taboo. Going back to the discussion.
It's not only the problem of having the onyx or the embolus coming back. It's also the fact that you are in a very important artery, and you can get spasm in it, and you're not. The problem is not occluding the ophthalmic artery; it's occluding the central arterial artery of the retina, which is such a small little thing that maybe just a little spasm or a tiny little embolus that in the anterior spinal artery would do nothing, but there it will be, a massive complication. I think that's the worst complication you can have, losing sight in one eye. But so
the worst. I mean, I'm not gonna.
in this kind of application, in this kind of.
That's what I'm saying. Like, I'm not. Of course, it's horrible, but I'll say that like it's another eloquent territory, like amongst other eloquent territories that we have to work with. That's what I would say. Yeah.
I mean, the internal carotid itself is an eloquent territory.
Right, that's what he means. Someone is asking about radiotherapy. I would say my personal opinion, no. you know, if endovascularly you don't have the tools or, you know, the experience or the willingness to go ahead for it, I think surgery is very straightforward, as Tibor was saying, before really going to radiotherapy, which is like the effect on dural fistula is still to prove, in my opinion. So yeah.
From the home of the gamma knife, I strongly support your notion, Nathan. We tried dural fistulas. We stopped that in
All
the
right,
70s. In the 70s.
So,
But
Eitan, Max, what? So, being that I don't know if Doc Konziolka is still at NYU with you guys, but I remember before I left, he was saying, well, dural fistulas are, you know, treatable, and he has some series experience with series. Have you got involved in that more, and do we have more information about that?
No, because we really don't tend to do that. Other than we have some exceptional like Galen fistulas cases, but we're talking about, you know, less than maybe 2 or 3 in a decade. So, you know, I would say
historically we have not sent. Other people from the institution may have sent more, with predictable results. The results are bad.
I mean, it may shrink, it may reduce it, but so far I've never seen a cure from a.
So because the way I understood is the few cases that we sent were like tiny leftovers of, you know, of like a Peter's apex dural fistula or something like that, where you almost completely embolized it, but there's some remnant or something, and some very focal thing that could be, I don't know, and this could be one of those because it's kind of very focal, right? So hypothetically it may work, but I don't know.
Hey, story. I mean, I think the answer is we sent very few, and now we pretty much don't send any because there's stuff gets better, the things get better. There's like one way or another we can finish them off.
Thank you.
Okay, so thank you, Bright, and thank you everyone. Dodi, because of the timing, actually something very interesting that we need to discuss. Dodi has a presentation on some important anatomical points, talking about like vessels and, you know, basically we want to get into this discussion. Like this case actually illustrates this. You know, you do an injection, you think you know the feeders, you know, this whole talk about feeders. There's like an exhaust, then, you know, they're like, you can't number these feeders. And the moment you inject something, you see something else. Not because some growth factor, like somehow like a VG, whatever. It's just like this is just pure hemodynamics, right? It's happening in real time. And if you put your microcatheter somewhere else, you're going to see other 10 feeders. So, you know, this is what I think, Dodi, if I don't know, if I'm kind of laying it up for you to do the slam dunk next time. So we didn't get a chance. So we're going to start next time with Dodi's discussion of like how we should see anatomy and vessels, and I think that's very important. So thank you all for again coming and sticking around for 3 hours plus. Yeah. And it'll be online. You'll be able to, you know, tell those who didn't come to please come and look. Thank you. And have a good day, evening, night. Thank you.
Thank you, guys. Bye.
Thank you.